Okay, thank you for your kind introduction. My name is Sean Mosai. I'm a nephrologist in Taiwan. I'm also an associate professor in the National Zhongxin University. Now I'm going to talk about entitled how to deal with patients with cardiorenal metabolic disease in different stages. Now, when we face the patient with diabetes mellitus, there are many challenges, such as body weight reduction, body weight control, or many comorbidity or cause, and so on. So today I just want to share two cases. The first one is the early stage, and the second one is the very advanced stage of CKD. And my experience is very simple. The first one is the early elevator, and the second one is fire and forget. Okay, now I'm going to talk about the first one case. The focus is in the first one case is improved glycemic management. This is my patient, Mr. Chen. He is a 70 years old man, and he has been already retired. But after his retirement, he is very busy. He always talk to me, "Oh, I'm very busy. I always forget to take a medicine." Okay, so the diabetes mellitus is a fresh diagnosis, maybe only 3 months. The blood pressure and the lipid profile were within normal limit. The BMI is also acceptable. The current medication is as follows. The metformin is, of course, it's a very high dose, 2,000 milligrams per day, and the ARB and the statin. So, but the blood glucose is not acceptable because the HbA1c is at 8.5%, and the AC blood glucose is 145 milligrams per deciliter. The ECG is normal sinus reason. The eGFR is 80 milliliter per minute. However, the UACR is 120 milligrams per gram. Okay, this is my my focus I will talk about later. Do you think the renal function is in early stage or late stage? The LDL is 70 milligrams per deciliter. I think it's good. So the focus for this patient, of course, is the sugar control. And how about early sugar control for this patient? And the single pill combination. And then the final focus is do you think for the kidney disease is early stage or late stage? So the first one is the benefit of sugar control. According to the previous, the speaker is also a nephrologist, and he's talking about hyperfiltration. Okay, the CKD is a vicious cycle status because the definition of CKD, patient with CKD, they always have nephron mass loss because the CKD, the definition is the prolonged kidney injury more than 3 months. So for CKD patient, they have renal mass loss, so the residual nephron often experience glomerular hyperfiltration. So it's a vicious case. It's a vicious cycle. So for every CKD patient, we try our best to control the glomerular hyperfiltration. As far as diabetes mellitus is concerned, patients with diabetes mellitus, once their blood glucose is out of control, they start to have glomerular hyperfiltration, regardless of renal injury or not. The glomerular hyperfiltration in DM patient is immediately, very early stage. This diagram shows the typical manifestation of diabetes mellitus. Before the UACR occurrence, patient once have glucose out of control, they start to have glomerular hyperfiltration. Their eGFR may be up to 180. It's a fat eGFR because it's a glomerular hyperfiltration. But why? As we know, if the glucose can be filtrated from glomerulus freely. So your blood glucose, if your blood glucose is 200 and the proximal tubular glucose concentration is almost the same, 200. So the proximal tubular glucose will be reabsorbed by the SGLT2 transporter. When the glucose reabsorbed, the sodium is also reabsorbed by the SGLT2 transporter. When the sodium was reabsorbed into the blood, the patient will have increased volume. The increased volume will also increase glomerular hyperfiltration. Then the decreased distal tubular sodium will deactivate T3 feedback. The deactivated T3 feedback will cause the efferent arterial vasodilatation and the efferent arterial vasoconstriction. So the increased sodium volume, the efferent vasodilatation, followed by efferent vasoconstriction, the birth 3 mechanisms all lead to the increased single nephron GFR, which means the glomerular hyperfiltration. The glomerular hyperfiltration is only based on glucose out of control. There is a foundation in kidney, the International Society of Nephrology. The International Society of Nephrology, they just published 60 breakthrough discoveries in the field of nephrology. As we know, after 1980, there are 4 breakthrough discoveries in nephrology. The first one is the glomerular hyperfiltration theory, followed by ACI-ARB. And as we know, the most important and the latest one is the discovery of SGLT2 inhibitor. Because the SGLT2 inhibitor can also control the hyperfiltration status, And it can help the ACI-ARB because ACI-ARB can cause efferent vasodilatation, and the H2 inhibitor can cause efferent vasoconstriction. So both drugs inhibitor and H2 inhibitor can control the glomerular hyperfiltration. In addition, the last two is the HIF. The HIF stabilizer is also very important in nephrology. And I will talk about later because H2 inhibitor can also increase the HIF stabilizer. So let me go back. My first experience is the glomerular hyperfiltration. My experience is that the culprit of DKD of glomerular hyperfiltration is based on blood sugar control. So if we control the blood glucose well, we will not have glomerular hyperfiltration. So control blood glucose is very important. Since the control blood glucose is very important, however, we don't postpone our patient as late as just like a patient in a ACCORD study. The ACCORD study, in ACCORD study, as we know, when you control patient's blood glucose, the patient they will not have the benefit in micro or macrovascular complication because that's too late. The patient in ACCORD study, the duration of DM is up to 10 years. So never postpone patient until 10 years. How about the onset of diabetes mellitus? As far as the metabolic disease is concerned, I think when we diagnose the diabetes mellitus, that's already too late because before the onset of diabetes mellitus, the metabolic syndrome or the insulin resistance already occurred 12 years ago. So we have to control blood glucose as early as possible because the dysglycemia latency effect occurred. So if you control your blood glucose too late, the dysglycemia latency effect will cause further injury, further organ injury. This is my study, which was published 3 years ago. We use the machine learning and we train an algorithm to diagnose the insulin resistance in CKD. Of course, I will not go into detail in my study, okay? But in the discussion, when patients they don't have diabetes mellitus, they just have insulin resistance. The insulin resistance is associated with atherosclerosis, CKD, and the CVD. Even they don't have diabetes mellitus, they just have insulin resistance. The insulin resistance is still associated with further organ damage. This is another study which we published last year, the clinical medicine in pediatrics is 17. I'm the first author, okay? So in this study, we also train a machine learning model to diagnose the insulin resistance in patients without diabetes mellitus. This study is based on enhanced a major database in Taiwan, and we also do clinical implication from the Taiwan Biobank database. Okay, I mean when you diagnose diabetes mellitus, I think it's also too late because the insulin resistance has also occurred 12 years ago. So don't control blood glucose too late. Okay, we have to control blood glucose as early as possible. We can try early combination. So don't let your patient delay treatment. Think about a cost study. Okay, that's too late. And when it comes to metabolic syndrome or insulin resistance, when the diagnosis of DM, in my opinion, is always too late. The insulin resistance has already occurred 12 years ago. So how about a combination therapy? As we know, the variation of blood glucose is very important in addition to AC sugar, PC sugar, and HbA1c. So the glucose variation is also very important. This is a study we published 4 years ago. This study is based on the database in my institute. When your patient, his HbA1c is less than 7, it seems like very good. However, the HbA1c variability is the highest. The patient also experiences renal function deterioration. So control blood glucose variation is very important. In my opinion, we have to control blood glucose as early as possible, and we have to control blood glucose variation. So in my opinion, we have to control blood glucose as early as possible because the superior doctor prevent disease. They say all the same from the Huangdi Neijing, okay, the superior doctor prevent disease. So we have to control blood glucose as early as possible. And so we have to control this patient blood glucose. And in addition to control blood glucose, we always measure UACR and the eGFR to evaluate the CV death and the renal event. So if we see this patient, the eGFR is here, however, the UACR is already here. So when it comes to the renal mass, he may experience the nearly 50% nephron mass loss. So in my opinion, for this patient, it's too late. It's too late. The risk for CV mortality increased 60%. And for the ESRD risk is about, the hazard ratio is about 3.8. So in my opinion, it's too late. So we always need to prescribe SGLT2 inhibitor for every DA patient because from the clinical guideline, the evidence is class 1A. The only one class 1A is SGLT2 inhibitor is here. So we have to prescribe SGLT2 inhibitor as many as possible to control blood glucose and to avoid any complication. And it can also treat CKD and heart failure. The second case is the more advanced CKD case. This patient is with 56 years old, housewife. The type 2 diabetes mellitus is already 8 years, and she experienced AMI and DKD. So she took the sulfonylurea and empagliflozin 10 milligram, but she always complained on the urinary tract infection. So what's the next? The blood glucose is still not at the target, and the eGFR is very low. It's already 30 milliliter per minute, and the UACR is very high. So what's the next? In addition to blood glucose control, we have still considered the risk of CV and kidney disease. Of course, I will prescribe the Tradjenta for her because the glucose lowering effect of Tradjenta is independent from the baseline eGFR. So the blood glucose lowering effect from Tradjenta is very reliable, especially for this patient with very bad renal function. This patient also has the AMI. So based on the Carolina and the Carolina, the Tradjenta has very solid evidence for CV safety. The CV safety is very solid for the Tradjenta. In addition to the albuminuria, there are two types of the DP4 inhibitor can lower microalbuminuria. The first one is sansacretine, and the second one is the Tradjenta. Of course, I seldom prescribe the sansacretine because the sansacretine is associated with heart failure hospitalization. So I will prescribe Tradjenta for this patient because the combination DP4 inhibitor and the SGLT2 inhibitor can be lower the risk of the GTI and the UTI. So for this patient, I will prescribe Tradjenta for her. And the next question is, the ESRD risk is very high and the CV mortality risk is also very high. So the next question is, should I discontinue the empagliflozin for this patient in very end-stage renal disease? The answer is not, because the renal benefits and the heart function benefits of empagliflozin is independent from the diabetes status, the eGFR status, and the UACR status. Of course, in addition to the heart and the renal protection, in my previous article, we also found the SGLT2 inhibitor has benefit for kidney function. Maybe the mechanism, maybe it can lower the renal anemia, because when we prescribe SGLT2 inhibitor, it can increase the HIF stabilizer, so it can also treat the renal anemia. It's a very important mechanism for the renal anemia treatment of SGLT2 inhibitor. When you prescribe SGLT2 inhibitor, it can increase the HIF stabilizer, and the increased HIF, it can also increase the EPO. For the CKD treatment, the anemia treatment is very vital for CKD. In addition, the benefit of empagliflozin, the CV benefit, the 3P mass, the heart failure hospitalization benefit, and the kidney function benefit is independent from baseline eGFR. So I will not discontinue empagliflozin for this patient with very end-stage CKD. And the pharmacokinetic for the empagliflozin, the peak plasma, the empagliflozin blood concentration is similar in advanced CKD. And the next question, if she went to the end-stage kidney disease and she started to receive hemodialysis, this medication is dialysable? Okay, the answer is not, because the molecular weight is high and is highly protein binding. So if your patient taking empagliflozin and undergoing hemodialysis, don't worry about that. It is not dialysable. There is a paper published 2 years ago, and it mentioned empagliflozin can be associated with the 32 protein, and the 9 very important protein also increased. And the 9 important protein is associated with cardio and the nephroprotection. They are renal function. They are independent from renal function. So maybe the empagliflozin, the cardio protection is not renal function dependent. So I will not withdraw this medication, because with some medication we will not have the kidney benefit anymore. So I will not discontinue this medication. And they are the protein published in this journal. Okay, they are associated with cardio protection. How about the kidney protection? There is a case series published last year. And in 7 patients undergoing hemodialysis, but they still with residual renal function. When you prescribe SGLT2 inhibitor, they can preserve renal function. So in this patient, okay, I will prescribe maybe glycine to lower the GTI and the UTI, and I will keep empagliflozin for this patient to have renal benefit and the cardiac benefit. If she went into the end-stage kidney disease, I think I will keep empagliflozin because it may be preserve renal function and it can have maybe heart protection. So the second experience of this patient is fire and forget for empagliflozin. He just prescribed and never discontinue this medication. This is my final slide. My experience, the first one is the superior doctor prevent disease. And then the second one is fire and forget. This is my presentation. Thanks for your attention.
So a very good afternoon to all the attendees and speakers. And it's my pleasure today to speak about how to manage difficult patients with cardiorenal metabolic syndrome and what are the treatment objectives in different disease stage. So in the next 25 to 30 minutes or so, I will try to discuss quite similar to what Dr. Tsai has been discussing in the previous talk, but trying to illustrate more dimension regarding the use of SGLT2 in treating patients with cardiorenal metabolic syndrome. So as we all know that CRM or cardiorenal metabolic conditions are intimately interconnected. Okay, so one disease can lead to another, or both of the disease could occur together. So for example, for type 2 diabetes, we know that 1/3 of these patients are likely to have underlying cardiovascular diseases, and that 37% of adults with diabetes will progress to CKD. Now, patients with CKD, again, are at risk of cardiovascular diseases, as well as those with cardiovascular diseases. As we all know, they are also prone to having kidney problems. So all in all, we know that these three conditions are very likely to occur together. So before we go on, I would like to share a publication we have performed about 2 years ago, which tried to look at the DM patients in Hong Kong and whether the CKD and heart failure's temporal associations affects the subsequent outcome, etc. So in this particular study, we included over 100,000 patients with type 2 diabetes, and 81,000 of them does not have CKD or heart failure, whereas 11,000 of these patients develop CKD subsequently, and 6,000 patients would develop heart failure. And interestingly, 3,200 patients develop both CKD and heart failure during the very same admission. So as I mentioned, these conditions could occur concomitantly. Importantly, we can see that in the table 2, the chance of patients with incident CKD in patients with already heart failure are much higher than those without heart failure. And in the same page, we know that patients who have CKD, as compared to those without CKD, are also more likely to have incident heart failure. So these two conditions not only occur commonly, but one of them, when they develop, they tend to lead to the subsequent problem. And as expected, we understand that those with concomitant CKD and heart failure has the worst clinical outcome, in particular all-cause mortality, and in this figure. So that we know that those without the green line, those without CKD and heart failure, they're likely to be much better. If you develop any of CKD or heart failure, your outcome will be worse. But once you develop these two conditions together, the outcome will be even worse. So therefore, if we have new medications that can prevent heart failure and CKD in patients with type 2 diabetes, that would be a great news to our patients. Now, screening, diagnosis, intervention, as I mentioned, if we can intervene early, we can prevent all these unnecessary complications. Not only that they don't need to see a cardiologist or nephrologist, but their outcome will be much better. So therefore, screening for these conditions early will be beneficial, and perhaps starting treatment early will even be better in order to prevent the development of cardiovascular outcome or kidney outcome. I'm sure many of our speakers today have mentioned the mechanisms of SGLT2 and why the use of SGLT2 not only improves glycemic control, but it also increased diuresis, glucose excretions, natriuresis, etc. So that we know this will be preventive, not only to the glucose control, but also will have a beneficial effect to our heart as well as the kidney functions. Interestingly, as we can show in this particular figure, just the overall metabolic benefits in patients with type 2 diabetes with SGLT2. As expected, we know that HbA1c will be much improved or reduced. The blood pressure as well, we can see that usually our patients will have a slight drop of blood pressure. But very interestingly, we know that the weight is also significantly reduced. So with regards to cardiorenal metabolic syndrome, I think body weight, although it's not in the equation, but this is something that we should also be considering when dealing with patients with type 2 diabetes. As such, I would like to bring the attention to the audience about another particular study that we performed about 4 years ago that tried to illustrate how obesity affects the cardiovascular, structural, and functional damage in patients with type 2 diabetes. So in this particular study, we have over 2,070 patients with type 2 diabetes, and we did a prospective echocardiographic assessment, not only the systolic function, diastolic function, but also the LV geometry, such as LV mass index, etc. So what we did is we not only look at the baseline, but we follow up these patients. And as shown in figure 2, we see a significant change or increase in the chance of having LV adverse remodeling, namely concentric hypertrophy. And also in figure 3, we see the diastolic dysfunction is also worsened in patients with type 2 diabetes overall. Interestingly, when we categorize patients with obesity, overweight, and normal weight using our Asian criteria, we can see the marked change of LVH as well as diastolic function are likely to occur more commonly in patients with obesity. As such, not only we know CKD would worsen heart failure, but metabolically, obesity itself will also be an influential factor for LV structural remodeling. So SGLT2, with the ability of weight reduction, perhaps would also contribute to the improved cardiovascular outcome in patients with type 2 diabetes, such that obesity should be also a consideration when we start patients with SGLT2. Now, talking about SGLT2, we know it is not only a diabetic drug, but it also provides cardiovascular outcome data that I will not repeat myself because I'm sure that's the 3-point MACE, cardiovascular death, heart failure hospitalization, and cardiovascular death plus heart failure hospitalization are reduced in patients receiving empagliflozin, as well as kidney outcome. So that we know that SGLT2 not only improves cardiac the diabetic control, but also improves the heart failure or cardiovascular adverse event. Another very common problem we see as cardiologists is arrhythmias. I'm sure that we know the CHA score, the use of DOAC, etc., prevents the occurrence of arrhythmic-related stroke in patients with high CHA score and atrial fibrillation. So this study is a meta-analysis that we performed about 3 years ago, which looks at the use of SGLT2 compared to placebo and the related risk of developing arrhythmias. So in this study, we included all the available randomized study and also compiled them into this meta-analysis, not only looking at empagliflozin, but the other types of SGLT2 as well. So as shown in this first part here, we know that patients with SGLT2 would have a lower risk of atrial fibrillation, flutters, embolic stroke, VT, as well as cardiac arrest. So in addition to the usual 3-point MACE, heart failure, etc., we have further evidence that the use of SGLT2 would reduce arrhythmias, another very common, yes, a difficult problem for cardiac patients. Now we go back to empagliflozin in patients with heart failure, as we know that heart failure is common, as I mentioned, patients with diabetes, but also there are studies showing that even patients without diabetes, the use of SGLT2 would be useful. So this is the overall journey of SGLT2. I think our previous speakers might have already mentioned some of it. In particular, we look at the effect of SGLT2 in patients with differential ejection fraction. So I think for the audience, we know that we cardiologists, although it's a very old parameter, ejection fraction, yet we are always concerned about the ejection fraction of patients, because in the old days, we know that the treatment of reduced ejection fraction, that is those with less than 40%, has a lot of medications or device therapy, whereas those with preserved ejection fraction, that is ejection fraction of over 40, has no particular treatment that has been shown to be beneficial. However, the advent of SGLT2 has become a game changer, such that not only those with reduced ejection fraction will have a 25% of reduction of cardiovascular death or heart failure hospitalization, but those with preserved ejection fraction would also lead to a significant reduction of adverse cardiovascular events. Mind you, these studies include both patients with and without type 2 diabetes. So this is something that we are very happy to see. And we use these Kaplan-Meier to look at the effect of these drugs so that we know that those who reduce and preserve EF patients would have an improved outcome. And the improved outcome occurs very early once we initiate the drug. So therefore, we advocate once the patients develop heart failure symptoms, those with different stages, one of the aim of today's talk. With heart failure symptoms, be it a preserved or reduced ejection fraction, an early initiation of SGLT2 should be advocated to these patients. Now, this is just another table to illustrate different hazard ratios. And interestingly, the kidney functions in patients who has heart failure, such that kidney function also improves accordingly in both patients with and without impaired ejection fraction. And looking at this Kaplan-Meier, we also try to look at the use of empagliflozin, whether the use of such would have a differential outcome difference in terms of heart failure as an endpoint or cardiovascular death in patients with and without CKD. So clearly, we can see that irrespective of the underlying kidney function, the use of empagliflozin or SGLT2 inhibitors would convey an improved outcome in patients both with and without CKD. And of course, we also are concerned about the subsequent side effects, of such drug. And one of those is UTI. I won't spend too much time to talk about UTI yet because we don't have a lot of data, but we know UTI is not an uncommon problem. However, there are studies coming out showing that SGLT2 and placebo, they might have, not as such a huge difference in terms of UTI infections, especially those with severe UTI infection. But nonetheless, educating the patients about UTI and other side effects such as genital infections or hypoglycemias or kidney injury will also be needed. Now, this is another graph to show that the hazard ratio are all below 1, except those with super high EF in patients taking SGLT2, so that a whole spectrum of patients with EF and heart failure would be useful when taking SGLT2 inhibitors. Fourth, we talk about CKD. So I know that the last speakers have mentioned about CKD and also some very interesting studies. So I wouldn't bore everyone about and repeating myself that CKD trials have been published and well accepted in a lot of guidelines. So we can see that the journey of CKD in patients with CKD with and without type 2 diabetes occurs in both dapagliflozin and empagliflozin. So this is such that I think there's a class effect without doubt about this. So when we talk about empagliflozin, that is empagliflozin versus placebo, okay, some of the difference is the inclusion criteria compared to the other trials that I will mention a little bit more. But of course, the outcome that they are concerned is the kidney function deterioration or any need of dialysis or renal death, etc. Now, the baseline characteristics of the empagliflozin EMPA-KIDNEY study, we can see that not everyone, but only 31% of these patients have diabetes. So majority of the patients with CKD does not have a underlying diabetes. So we are not treating this as a diabetic patients. Interestingly, we're looking at the purple box, okay? So the inclusion criteria is less stringent, I must say, compared to the dapagliflozin or the other study where they would need the presence of albuminuria. But the empagliflozin study seems to have recruited less severe patients and even those without or only very mildly increased albuminuria, so that the population that could benefit from kidney outcomes seems to be the population seems to be greater compared to the other drugs. Now, looking at the Kaplan-Meier again, we see that the kidney disease progression as well as cardiovascular death is much better in patients with empagliflozin. But we can see that now the outcome usually occurs about 1 year after that. I will come back to this later because this is something very interesting that I would love to share. Now we look at the key outcome, secondary outcomes such as all-cause hospitalization with the hazard ratio of 0.86, heart failure and cardiovascular death, and all-cause mortality. They are all pointing towards a beneficial effect in CKD patients using empagliflozin. So that we know that the composite primary outcome as well as key secondary outcomes are supportive. And in particular, the use of empagliflozin in those with less albuminuria is worth mentioning and also consideration when starting patients with SGLT2 inhibitors. Now we look at the placebos and empagliflozin, we can see again the UTI and genital infection serious dose seems to have similar outcome. So again, although we know that this is an association with urinary tract infection, with appropriate education, I think this is not something that we are very worried about. Talking about CKD, I think one must always look for hyperkalemia, which we know again is a very common problem in patients with diabetes because of renal tubular acidosis, etc., and in addition to CKD. So we did a very interesting study to look at the risk of hyperkalemia in patients with type 2 diabetes and comparing the use of SGLT2 versus DPP4 inhibitors. So this is just published about 3-4 months ago in the European Heart Journal Cardiovascular Pharmacotherapy. So we try to answer the questions whether hyperkalemia is a worrying side effect will be less common in patients with SGLT2 inhibitors. So in this particular study, we have included 11,000 patients with SGLT2 inhibitors versus 57,000 patients with DPP4 in Hong Kong. We look at several outcomes, including severe hyperkalemia, short-term severe hyperkalemia of within 30 days of the initiation of the drug, long-term severe hyperkalemia, and the need of initiation of potassium balance. These are the common outcomes that people look at when looking at studies with regard to risk of hyperkalemia and also hypokalemia. So we see that the use of SGLT2 inhibitors always protect patients to hyperkalemia irrespective of different definition, and that the risk of hypokalemia are similar, okay, comparing to with DPP4 inhibitors. So that we know the use of SGLT2 inhibitors protects against kidney dysfunction as well as the risk of hyperkalemia, because we know hyperkalemia is a significant adverse outcome that is associated with adverse mortality, etc. And looking at the forest plot, we can see that although there seems to be no interaction with different subgroups, but the use of SGLT2 versus DPP4 inhibitors seems to be effective in terms of preventing hyperkalemia in both, for example, age as well as different types of SGLT2 inhibitors, including empagliflozin. So now we look at the international guidelines. So we know that the usual ADA guidelines recommend initial therapy of SGLT2 inhibitors, especially those with risk of ASCVD, heart failure, CKD, should initiate SGLT2 inhibitors. So even before they develop such outcome, as we are talking about managing early, or when we start this drug, when they develop such complications, SGLT2 should be given at almost all stages of cardiorenal outcome. All right. So for the clinical practice for the kidney outcome, again, it is recommended as a first-line therapy for patients with diabetes and CKD, and of course those, as I mentioned, with risk of heart failure. So this is the ADA algorithm, which I think is very informative, such that those with ASCVD, they should start with SGLT2 inhibitors or GLP-1 agonists. Of course, we are more familiar with the SGLT2 inhibitors, as well as when we use it for patients already have heart failure and CKD, SGLT2 is the preferable drug to initiate in patients with both of these complications once they developed. Now we look at the clinical recommendations for treating patients with type 2 diabetes and CKD. So what do they recommend? They recommend, of course, first-line therapy with metformin only if they have a good EGFR, but with those when they develop more severe kidney dysfunction, we should discontinue because of the risk of lactic acidosis. And SGLT2 inhibitors, we can consider starting even though the EGFR is near 20 or above, but then when we are taking dialysis, etc., we know that we should consider to discontinue the drug. So for the heart failure guideline, I think I have illustrates the importance of the use of SGLT2 inhibitors for those with reduced and preserved ejection fraction. So that these are all the European guideline. The American guideline has strongly recommended SGLT2 as a first-line ejection fraction, irrespective of the ejection fraction in patients with heart failure. So these are the recommendations with a class 1A, which is the highest recommendations for patients with heart failure, even in patients with preserved ejection fraction. Now you can see that we know reduced ejection fraction or mid-range ejection fraction, we know there are 4 pillars, MRA, beta blockers, etc. But therefore, HFpEF, SGLT2 inhibitors are the only drug that would modulate the outcome, in addition to fluid control by diuresis. In the final 3-5 minutes or so, I will talk about the practical tips when we are treating patients with different diseases and how we tackle with the SGLT2 inhibitor. So the good thing about SGLT2 inhibitors is that it is a once daily single dose without the need of titration. Okay, whereas compared to the others, we know that they have a lot of other considerations, and sometimes we need several doses. This is a very important slide with regards to my talk, because I'm sure a lot of our clinicians, especially those when we are to start patients with SGLT2 inhibitors in patients with impaired kidney function, we always check the kidney function for these patients, okay, which worry because of dehydration, etc., that we worry some kidney damage or impairment. So we can see from this particular graph here that, in fact, empagliflozin or dapagliflozin, when we initiate the SGLT2 inhibitors in the very early stage, it is very common to have a slight reduction of the eGFR or increase in the creatinine. You know, patients, especially those with kidney disease, are very concerned about eGFR and creatinine. They worry about dialysis. They worry about the subsequent treatment plan, because we know there are many treatments for end-stage kidney disease except dialysis or kidney transplantation. So people may come back to you and tell you that, oh, I am losing weight. I have a lot of urine output, and my renal function has worsened. Have you been giving me a wrong drug? So if we look at the graph here, we can see that, in fact, if we look at the overall trend of kidney functions, without doubt that the use of SGLT2 inhibitors will be much improved or better compared to those without. So there seems to be a rebound of SGLT2 inhibitors, and also will stabilize afterwards. So this is something that we have to worry about, and not to worry about, but keep it in mind so that we can educate our patients. So this is a case that I had recently, who is an 80-year-old man with PAF and hypertension, pre-diabetes, with a body weight of 95 kilograms and some degree of kidney disease, eGFR of 32. So he comes to me not only to start anticoagulation, but he wants to make sure that his kidney function would not worsen. Of course, I consulted our nephrologist colleague with regard to this patient. But yet, after further discussion, we control his hypertension, etc. We give NOAC, but we think that it is an appropriate case, perhaps, to start SGLT2 inhibitors. So, before we do that, we look at the drug treatment, including entresto, amlodipine, episaban, dronedarone for rhythm control and beta loss shock. So the blood pressure is fine. The patient is a little bit overweight, and the kidney function is impaired. So it's a classic example of patients, and of course he has AF. So a classic example of patients which might benefit from SGLT2 inhibitors. So we decided, after further discussion with the patient and also the relatives, we start the eGFR, and we look at the eGFR in this patient. This is real data. We look at the eGFR has worsened 2 weeks later, but subsequently I asked the patient to trust me and keep taking the drug, and after 6 months of time, the eGFR rebound to a normal or the baseline level, and hopefully it will stabilize and remain at that stage after more time of follow-up. So I think we also need to educate the patients, the tips and tricks, not only the CKD, but also we need genital hygiene. We need to consider to pause the SGLT2 inhibitors in patients with acute illnesses or surgery, and also when following up, we have to make sure that the kidney function is not worsened to a stage that is not in a difficult state that we might have to initiate a dialysis, etc. So there has been a lot of arguments about stopping the SGLT2 inhibitors, but usually if the drug is not stopped, we monitor the blood pressure, we monitor the ketones, because we know ketoacidosis could be a problem. But if we decided to stop it, we can restart it once the patient has stabilized, or even within after 24 hours of having the surgery. Okay, these are the conditions that we consider to pause it, like severe medical illnesses. Of course, if they are dehydrated, okay, they are having a major infection, and surgical procedures. And ketoacidosis is rare, but potentially life-threatening, that we clinicians should be aware of. That if the patient comes to you with confusion, difficult breathing, vomiting, anorexia, abdominal pain, classical symptoms of ketoacidosis, remember to check the serum ketone. Okay, so this is important, and we have to stop the SGLT2 immediately. So these are the overall suggestions, or the summary of today's talk, which we know that holistic management of risk factors, and in particular, DM, heart failure, CKD are interrelated conditions. Screening, diagnosis, and interventions early to protect all these complications, or even once they develop, we should consider starting SGLT2 inhibitors. It is a very good safety profile, well tolerated, and convenient once daily dose is sufficient. And international guidelines and as well as our clinical practice, looking at our own data, know that early foundation of SGLT2 inhibitors are useful in patients with DM, heart failure, and CKD. With that, I conclude my talk and look forward to the discussion afterwards. Thank you.